fine. I always keep on saying that when it comes to the cancer, the first thing what has to come to our mind is not the malnutrition, it is the inflammation. So, however, around a decade back, there was not much information available on cancer and its impact on the metabolism or the nutrition. In the last few years, a lot of development has been taken place. Good research have come out, and the understanding of cancer cells pertaining to the nutritional impact, and further to that one, for the survival as well as during the treatment as well, how they behave. It has a lot of implications upon how an individual throughout their journey during the treatment, what all things they undergo. And if we don't understand what is inflammation and its impact on that, on the individual's body as well as on the treatment side effects, I always say that we will be doing injustice to the cancer patient who we are catering to. Uh, I'm going to talk about, as I said, only the inflammation and its relation with the nutrition. However, I didn't get much time to plan a case study kind of a thing, which I flyerized just 2 days back, where it was mentioned that it will be a case study kind of presentation. But I'm really sorry I couldn't actually make it out. But I'm quite sure this first slide will make you a lot of understanding regarding how a case has to be handled. So I would request the audience to pay attention to the entire presentation as well. But the first slide will be something like how you are going to interpret the inflammation and which are those markers, what you would like to identify them when you are seeing the patient maybe for the first time or during maybe the follow-up, during your follow-ups as well. So this is a hypothetical case. I'm putting it across like a 46-year-old man or a woman, you can say, who is
Yeah.
diagnosed with
Can I?
pancreatic cancer.
Your voice is not very clear. Can we make it a little more audible? I mean, there is a lot of disturbance
Yeah.
behind it.
Louder. Is this fine?
Yeah, this looks better. Thank you.
Yeah. Uh, is a 46-year-old man or a woman, whatever the way we can consider this subject has to be, diagnosed with periambulary pancreatic cancer. I've considered periambulary pancreatic cancer because most of the times the malnutrition is very, very aggressive in such kind of cancers. And they exhibit a lot of inflammatory markers. So that is the reason why I designed this study, this case study into periambulary pancreatic cancer. His usual weight was 72 kgs. Currently, he's weighing 65 kgs. It means there is a weight loss of more than 10%. And normally, it is being seen that the pancreatic cancers, periambulary pancreatic cancer patients, normally, when by the time they report to us, they have lost more than 5% or maybe that more than 10% weight loss. A more than 10% weight loss itself is an indication of inflammation. And having said that, I don't mean to say that 5% weight loss doesn't indicate inflammation. But 5% weight loss is something like a buffer kind of a thing, where we can work it out, where we can say we can reverse the weight loss, or inflammation may not be that aggressive. But as I said, if it's more than 10% weight loss, it's definitely an indicative of inflammatory condition. So you don't have to go through any kind of a parameters as well. This is how I would analyze a cancer patient when I would like to see how far the inflammation has been set up in this particular individual. And I said this patient has no comorbidities. Deliberately, I put it across. In reality, around 50 to 55% of the patients, cancer patients, have some comorbidities. To ease out your understanding, I have removed the comorbidity over here. The patient doesn't have diabetes or doesn't has any renal issues and no known diseases the patient is reporting to us. And this is how the pancreatic cancer, the image what you can see over here. This is the liver part over here and the gallbladder, and this is the common bile duct, and this is what you see the pancreas, head of the pancreas, where the common bile duct has been in touch with the duodenum part, and here the cancer has occurred, and this cancer is pushing the duct, making the bile flow is not the bile flow is not happening. So there is a constriction, or you can say there is a pressure created by the tumor on the bile ducts. That is the reason why the bile is not available for the digestion. Why did I put this picture? The entire this picture will be again depending upon the following bullets what I'm going to talk about it over here. As I said, the patient has no comorbidity, but he reported that his fasting blood sugar was 135. So it means that the patient is hyperglycemic, and hyperglycemic, why it can be, the further slides will be, I will be explaining it to you. He reported with a serum albumin of 2.5. Now we know the serum albumin is an inflammatory marker. It's just not the inflammatory marker, but if you go and try to analyze in a further, more scientific way, and if you can calculate AG ratio, that is the albumin globulin ratio, so it came to 0.7. It is less than 1. It means that there is an inflammation. This is one more factor what you can consider over here to analyze whether the patient is into an inflammatory condition or not. CRP, we all know it's an indicator of inflammation. Anything above 1 or even less than 1, any kind of a number of CRP is an inflammation. But as the numbers increase, the gravity of the inflammation increases. Here I have quoted as 10.4. Even it can be 2 or 3. That doesn't mean that there is no inflammation. Even CRP value of 2 is an indicator of inflammation, of a low grade inflammation, you can see. This patient reported total bilirubin to be 22.3 now. So this is the reason why I choose this picture to put it across. As I said, there is a blockage. There is a blockage of bile flow over here. Bile is not available. So that is why the total bilirubin has increased to 22.3. There's a fat malabsorption which is happening. And this is where we will be concerned about bilirubin to be resting, maybe reducing at the earliest possible time. The increase of bilirubin has some impact on the kind of symptoms they exhibit, which again I'll be talking about when the bullet point comes over there. So as of now, we understand there is a blockage at the periambullary part. Biles are not being flowed, and total bilirubin, what we are seeing is 22.3. Now there's one more thing, tumor markers, which is normally being conducted for any pancreatic or hepatopancreatic biliary disorders, CA 19.9. And CA 19.9 happens to be 74, which is again indicating higher inflammation over here. CA 19.9 does not necessarily mean the patient has cancer. CA 19.9 says that there is something wrong with the pancreas. It may be pancreatitis. So this is how you have to interpret. But now, because we are dealing with all cancer patients, for us to relate increased CA 19.9 to the cancer is very easy. But you're working in a multi-specialty hospitals, and if the diagnosis is not yet complete, the 19.9 does not necessarily mean the patient has cancer. Hemoglobin 9.2. The reason why the patient is anemic, again, we will understand as we move ahead. Serum creatinine, he reported to be 1.8 over here. So why 1.8? Is it indicating some kind of a renal issues over here? But again, nothing to confirm over here as of now. The answer you may get it once you talk about the symptoms of the patients. So we will keep serum creatinine again over here as 1.8, hemoglobin also 9.2. Maybe we will get the answers as we move forward. Then we have the BUN, that is 48, which is increased, which is about 20. The normal value is optimum is 20. Now this is 48. BUN creatinine ratio, normally we don't do, but for the presentations, if you would like to understand, if you would like to do some kind of a research, so these are the calculations which might help you out in doing your research more sophisticatedly. BUN creatinine ratio is the normal value is something around from 10 to 20 is to 1. I repeat that normal BUN creatinine ratio is 10 to 20 is to 1. Here it is 26.7 to 1. So it means that it is elevated. Again, it is indicating inflammation. Then we have these lipid values being disturbed over here. However, most of the cancer patients, lipids we don't do. And if it is available, you can analyze. And here I have deliberately taken to make for this presentation the HDL as 20 mg, which has to be more than 40-50. We are seeing that HDL is very less, that is 20. Triglyceride, which has to be something around 150, which is almost double of that is 300. And LDL, which is again has to be near about 90 or 100, which is increased to 206. So there is a dyslipidemia being seen with this patient. Now we are now we are talking about the symptoms to this patient. Normally, the way when the patient comes, they will hand over the reports to you, and you saw the reports, and not necessary. Again, I make very clear over here to the budding dietitians or the students who are logged in. All pancreatic cancers will not be showing similar kind of report what I have projected on the screen. Of all these things, there may be availability of only few of them. 4 or 5 parameters may be available. Rest of them, it is not being that investigation is not conducted, or even if it is conducted, they may be normal. So I make the point very clear. Out of all these parameters, some may be shown elevated, some may be normal, and some investigations may not have been performed because it is not necessary. For example, in TMH, in normal circumstances, we don't do CRP because we know all cancer patients are there. So CRP will be elevated more or less with all the patients, unless until under the proper protocol, if certain patients need to be monitored for the inflammation, only they will be asked to do CRP, not all the patients. So we don't want to increase the cost of the patients just by doing unnecessary investigations. So this is how I make clear over here regarding the biochemical parameters. Now you see the patient is complaining of anorexia, nausea, occasional vomiting. So anorexia, nausea can be one of the result because of the total bilirubin, which is 22.3. Higher the bilirubin, normally the patients complain about poor appetite, anorexia, nausea, and vomiting. Lethargy, tiredness is complaining of, which can be because of low hemoglobin. That may be one of the reason. Now the dehydration, this may be because of the creatinine, which is 1.8. Because the patient is anorexic, patient will not be eating anything or eating very less than the daily requirement. And I keep on telling many of the times, any person who is eating less food will also be drinking very less water also. Maybe 1 or 2 glasses of fruit juice unless until the patient has met the dietitian and the dietitian has advised not to drink fruit juices. That's a different thing. I'm talking about the day one when the patient is coming to you and the patient has not reported anything, not met any of the dietitians. So here, as I said, the patient is having anorexia, more or less, definitely the patient will be dehydrated. And how this can be confirmed? Because of the serum creatinine, which is 1.8. Now here, some of the students may be wondering, one is also increased, creatinine is also increased. Is it maybe because of some kind of a CKD or some kind of a renal issues may be there with this patient? You're talking about a hypothetical possibility, but here, if the patient is a CKD, the second line, what did I mention about? The patient has no comorbidities. I have verified that one. The patient doesn't have comorbs, it means that the CKD is not present. So it directly relates to the dehydration part. However, I'm not the best person to come out with a diagnosis of this part, but having seen these many patients and understanding the pathophysiology of the anorexia, nausea, vomiting, all these things and the biochemical parameters, I'm talking about a possibility, and which is a very high possibility I'm talking about. Maybe the patient will undergo some more investigations, and if the treating doctor feels the patient has to undergo more investigations to rule out some kind of renal issues, that the treating doctor will take a call. So that is not my role as of now, but my analysis over here on day one when the patient is reporting to you, this is what I've analyzed. Of all these things, every factor is a indicator of inflammation. Uh, Assume that the patient forgot to bring any of the biochemical parameter reports, and he says, I couldn't get it. Either I've lost it or it is at home. But today I just made the file and I've come to you. So even then also, how you will identify the patient has inflammation? The last line, which I deliberately put it on a red color because of the symptoms. Anorexia itself, nausea, vomiting itself is an indicator of inflammation. Lethargy, tiredness is an indication of inflammation. And further to that, weight loss, I did mention about 10% weight loss. That is one of the strongest indicator of inflammation. So I trust that you all have understood how to identify inflammation. However, there are many more parameters. I'm going to talk about, there's one more slide which I've regarding the biochemical parameters, but to understand on a very casual way and maybe the most basic things what we need at the day one to understand the inflammation, these are more than enough for you. I did mention about this patient had his dyslipidemia. That is HDL is disturbed, TH, LDL, everything is disturbed. In what way that has any relation to do with the cancer? Let us understand. This I've taken from the study, what you can see it from the dyslipidemia and its relation with the cancer. Dyslipidemia, what we saw, increase of total cholesterol, increase of low density lipoprotein, increase of triglycerides, and reduced HDL. These are all again inflammatory indicators. What do? They increase inflammation, they increase oxidative stress, they reduce regulation of cell proliferation and growth. It means that the homeostasis of the body, the normalcy of the body has been disturbed over here. And it increases the immune compromise kind of a thing. It means that immunity is at risk. So these are the things result of dyslipidemia. And these factors are going to increase the risk of cancer development, and also it can worsen the prognosis of the cancer patients. So this is how the dyslipidemia, it is being seen that 13 to 14% of the patients have shown dyslipidemia and the cancer occurrences. However, it's not that very common, but because of this presentation, I have put it across to you. Now, there are really wonderful kind of calculations what you can do to understand the information further to the earlier slides what I presented to you. These are the neutrophil lymphocyte ratio, platelet lymphocyte ratio, platelet monocyte ratio, hemoglobin platelet ratio, hemoglobin lymphocyte ratio, lymphocyte monocyte ratio, and systemic immune inflammation index that is calculated by platelet into neutrophil divided by lymphocyte. This is how you can derive those numbers. And derived neutrophil lymphocyte ratios. These are all the again calculations which will give you an understanding about the prevalence of inflammation. And if you ask me, do we do all these calculations? Very frankly, we don't do. And we try to understand with the earlier slide what I spoke about. That is the one which what we normally follow. And this slide actually very exclusively talks about the hematological cancers, the inflammation in hematological cancers. It is understood that the solid cancers are always high inflammatory, and the liquid cancers, that is the leukemias, are of low inflammatory. But this is a wrong concept. It is not like that. However, the outcome of inflammation on the nutritional status in hematological cancers is totally different from the solid cancers. However, you may come across disturbed of all these ratios, which indicate a high inflammation, but their nutritional status will be more or less very good. Hematological cancers, if you see, they hardly lose weight. They hardly exhibit any kind of a symptom, maybe fever or at certain times, some kind of a GI disturbances. But they don't exhibit very regular kind of a symptoms or disturbed biochemical parameters, not the CBC I'm talking about. Biochemistry parameters will be disturbed in solid cancers. So you see biochemistry more disturbed in solid cancers, and you see CBC more disturbed in hematological cancers. Again, I would like to make it very clear that doesn't mean the CBC is not disturbed in solid cancers or vice versa. They will be. But I'm talking about on a larger scale. When you see hematological cancers, obviously CBC will be disturbed. And more or less, the biochemistry is more or less not disturbed, I would say like that. Now, exploring the interplay between this tumor-induced inflammation, metabolic dysfunction, and the nutritional status, we will try to understand the mechanisms over here, why these biochemical parameters are disturbed. We all know the role of macrophage. It is one of those WBCs, the white blood cells, which actually removes all the debris from the circulation and eliminates from the body. And once the tumor cells are dead also, the tumor cells will be engulfed by it and it will be thrown out of the body. This is what the macrophage does. It is something like a scavenger, you say. And you have these T helper cells and many other cells which will identify cancer cells and they will kill the cancer cells. Now it means that macrophage is something of a friend of a T cell, which is actually waiting the T cell to kill the cancer cell so that it will remove that dead cancer cell out of the body. But here what happens, if the inflammation increases because of IL-10, IL-6, IL-10 is an anti-inflammatory and IL-6 is a pro-inflammatory. TNF-alpha is again a pro-inflammatory. So because of disturbance about all these cytokines, the macrophage actually forgets about its role of eliminating the tumor cell, and it starts helping the tumor cell. And because of this, there are certain kind of vicious cycles which are formed. I will again explain this different than the one what I spoke about over here. We know that it is the stress which induces, which damages the DNAs. And why the DNA gets damaged? Because of the reactive oxygen species, which is being produced because of the stress level. These ROS actually increases the necrosis factor kappa B, and this NFKB increases IL-1, IL-6, and TNF alpha. It means that they all are inflammatory markers. So ROS increase NFKB, and NFKB increase the production of IL-1, IL-6, and TNF alpha. TNF alpha, again, it impacts the STAT3. STAT3 is nothing but signal transducer and activated transcription of 3. This STAT3 actually is stored in muscle mass. When there is a catabolism happening because of these cytokines, the muscle is being broken down and the STAT3 is being released into the circulation. STAT3 becomes a friend to the IL-6, which is again an inflammatory marker. And this IL-6 we know which is going to instigate many of the catabolic process. One of them is the JK process. And the JK process again increases the STAT3 release. So there's a vicious cycle over here. Again, NFKB increases the TNF alpha, which is again increasing the STAT3. Again, this is going to increase IL-6. And again, we have a vicious cycle over here. Then we have this hypoxia being created by the tumor. Once there is a tumor being formed, it's the tumor likes a situation where oxygen is very less and the environment should be acidic. When I'm talking about all these things, these are all related to the nutrition, what I'm actually talking about. You'll come across as you go on listening to the next test. You may be feeling this pathophysiology, which may not be related with my nutrition practice. As I said, the tumor cells induces hypoxia. And hypoxia has a many roles over there. One of them is the hypoxia inducing factor release of that one. Again, this hypoxia condition, HIF, which is going to increase the IL-6 release over here. Now you can see there are so many vicious cycles happening just because presence of the tumor cell and the failure of the macrophage. It is just not the macrophage. There are many other elements. There are many other DNAs also which fail over there to arrest the tumor cell, but that's a totally different topic which is not related to the nutrition directly. So I'm not going to talk about it. So we understood that there is a failure of the immune system. The immune system has not taken care of the tumor cell. Tumor cell induced hypoxia, and hypoxia is inducing many of these inflammatory markers, and which is also complemented by the ROS activity, which is helping them to become more inflammatory condition. Now the inflammation is setting. What happens once the inflammation sets in? I always say that cancer, once there's a tumor, it is more powerful than the brain because it defies the brain signals. All our body activities are actually controlled by the brain. Whatever you would like to do, think or say or see, everything is being controlled by the brain. But here, somehow, the things are not into that kind of a perspective of a natural thing, what way it has to function. Here, all wrong messages are sent to the hypothalamus, and hypothalamus is inducing many other activations which are actually catabolic in nature. That is the adrenergic activation, which starts catabolizing the fat deposits into the body, whatever the fat deposits the patient has, through the lipolysis, where the fat deposits are broken down into free fatty acids. These free fatty acids are sent to the liver. I will come to this point again when I speak about the muscle mass. Now, it increases the hypogonadism. This hypogonadism, if you see, it starts breaking the muscle mass. When the muscle mass is broken down, amino acids are released. I did mention in the last slide, when the muscle mass is broken down, STAT3 is also released. So STAT3 has, we understood what it is doing. It is going to increase IL-1, IL-6, TNF alpha, release of that one. Again, we don't want to repeat that over here, but we know that it's a very complicated thing over here. The breakdown of muscle mass is the release of amino acids and STAT3. This amino acid again reaches to the liver. So free fatty acids, amino acids, when they reach the liver only thinks that the provision of free fatty acids and amino acids have come to its arena only to be produced as ATP or converted to glucose. So through gluconeogenesis, amino acids and free fatty acids are converted to glucose. And now you might have heard many times I speak about the cancer likes glucose and it thrives upon glucose. The more the glucose, the more stronger it grows upon. So this glucose is utilized by the cancer, that is the tumor cells. While utilizing the glucose, only 15% of the glucose is being utilized for its growth, and remaining 85% of the glucose molecule is converted to lactate. And the lactate is nothing but the lactic acid. When 85% of the lactic acid is being produced, I did mention cancer cells thrive upon the hypoxia and the acidic medium. Now we know that both the systems are made available by cancer itself, and one of them is the provision of glucose. So we can curtail upon to the glucose to reduce the production of the lactate. This is what we would like to practice upon. I will come to this point again as we move on. So this lactate, when it reaches to the liver, through the Cori cycle, again it is being converted to the glucose. Now we have again a vicious cycle where the glucose provision is being provided by the glucose, converting it to the lactate, and lactate converting it to the glucose. So we have a lot of things being wasted over here without any profits. I mean to the without any anabolic reactions. Everything is into a catabolic reaction. When there is a provision of nutrient supply to the cancer cells, it is using glucose for its own growth through all these mechanisms. I did mention about the ATP will be produced, that the lactate will be produced, and it is seen that all resources for the cancer cells growth are being handled by the mitochondria. And in cancer cells, mitochondria is actually being damaged. A damaged mitochondria gives a way, kind of a easy pathways to provide all the nutrients for the cancer cells. So in one line, I would say all cancer patients' mitochondria are being damaged. In a very simple language, I would say. At certain times, even glutamine also helps the mitochondria uses glutamine to produce ATP when glucose is not available. It means that when you are not feeding, sometimes the glutamine is being also used as a fuel for the growth. However, just not the glutamine. When you are not feeding the patient, certain times when the muscle is broken down, the branch chain amino acids which are into the muscles are also being released. And in certain cancers, it has been seen that the mitochondria uses branch chain amino acids to fuel the cancer cell. It's a very complicated situation. Now you may be saying glutamine is also fuel, branch chain amino acid is also fuel, glucose is also fuel. So what we need to feed to the patient? Very tricky situation. Understanding muscles are being broken down, fats are being broken down, everything is being sent to the liver to produce the ATP, which is going to the cancer cell. Again, the lactate is being produced. Tumor, as did mention, that they are very smart enough to make the micro environment. It means that around them, all the situations will be the way they want. It is something like a dog. He wants everything to be placed the way he wants. Any person would like to do any kind of illegal activity, he has to just tell and it will be done. No policeman, no law can touch them. In similar line, this is a dawn. The cancer cells become a dawn, and it sees that the microenvironment, no one is going to harm it. And in fact, whatever is there around it, including the macrophages, dendritic cells, native T cells, all these things are actually helping them because they have failed to arrest the activities of the tumor. Initially, there is a suppression of immune cells, which actually paves the ways for the cancer cell to progress. If they are very strong enough, they will not allow the cancer cell to grow. But here they have failed. That is why there is a progression of the cancer cell. Then when the progression as it continues, there is an angiogenesis. Angiogenesis is nothing but supply of food for the cancer cells. The cancer cells will only grow when there is a continuous supply of the fuel what it requires. And this can be done only if there is a blood supply to the tumors. And to generate that blood supply, all these factors which are protective in nature, which have failed, and through these cytokines, angiogenesis is being created, and the blood supply is being created so that the cancer cells are growing. Further, if it is not being taken care of, then we have this metastasis where the cells have gone to some other part of the body where the secondary tumors have grown. So we have a very dangerous situation over here. This is happening only because of the amplified inflammation over here. So what if we can reduce the inflammation, then can we really do some wonders to these the cancer patient? That is what we need to answer. So coming to this metabolic changes driven by the inflammation. So what are those changes? Chronic inflammation shifts metabolism to support tumor growth. This is what we understood in the last few slides. This increased glycolysis through Warburg effect and lipid metabolism and amino acids. I did speak about the same thing in the earlier, where the fat deposits, the muscles which are broken down and being utilized for the glucose production. And even the glycolysis, I did mention about 85% is being converted to the lactic acid, only 15% is being used by the cancer cell. That is nothing but the worm. Now, the role of hypoxia and nutrient deprivation in altering the metabolic pathway. We saw even, so it's something kind of summary of the previous slides. Pro-inflammatory cytokines, that is the IL-1, IL-6, and TNF-alpha, they contribute to break down the skeletal muscle and fat loss of the adipose tissue. Can we reduce the circulation of IL-1, IL-6, and TNF-alpha through the nutrition? We will speak about it. Systemic inflammation alters energy balance, increasing the resting energy expenditure. When this is again a very tricky situation, when the patient is into a catabolic condition, it means that where the patient is losing his fat mass and muscle mass, then why there is an increase of resting energy expenditure? Both the situations are actually opposite to each other, where a person is losing and there is an increase of resting energy expenditure. It is because the tumor is growing. If the tumor is growing, it needs energy. So it means that the patient, even at rest, the requirement of the energy is always higher. So that is why there's an increase in resting energy expenditure for the cancer patient. So it means the requirement of energy is higher over here. Now, in what form of the energy you will be providing? If you provide good amount of carbohydrates, we are seeing that IL-1 and 6 TNF alpha has been increased. So I don't want this to happen. Then what is remaining? What is the second source of the energy? That is the fat. Now, which kind of fat you would like to give? Good fats. Hyperglycemia induces insulin resistance. That is why we saw that the blood sugar was 135. I did mention about, I will answer this question in the later presentation. Why the patient is having hyperglycemia and when the patient is not diabetic? Because of lot of glucose which is being produced because of the breakdown of amino acids and the fats deposits which is being converted to the glucose into the circulation by the liver. This is why the insulin resistance has been occurred. Inflammation driven anorexia and reduced food intake because of the increased all those parameters and specifically the bilirubin where the patient is talking complaining about anorexia, and all these things are going to induce cachexia if not taken care of. Normally a patient who has lost more than 10% of weight of his usual weight is into cachectic part, which is in generally not reversible. So if it is less than 10%, most of the time you can stop the weight loss. I'm not saying you can increase the weight. It's a very daunting task. You can do so, but there are very few dedicated patients who really obey your orders, you whatever the counseling you have done, and they understand the importance of the nutrition. These numbers are very less. Yes, but we can do if it is 5 to 7% weight loss is then we can reverse. But if it once it crosses 10%, the patient happens to be in the cachectic. The case what I mentioned is a cachectic case. And immune compromise, I did mention about the failure of all the WBCs, which their role of killing the cancer cell and eliminating from the body is being not being performed. Inflammation and tumor as anti-nutrient factors, because there are certain kind of tumors which affect on the digestive systems, which affect upon the absorption of the certain kind of nutrients. However, not much explanation is not being given on the exactly what kind of digestive process and what kind of absorptive process the tumors do interfere. But we have seen that patient was anemic. That may be because of the low consumption of the food, or maybe the tumor itself, as I said, will have a certain kind of impact on the digestive system because the tumor is located at the periampullary or maybe into the pancreas, where the pancreatic juice is also not available along with the bile.
তাহলে এখন ওরা অনশন চালিয়ে যাবে?
So you can understand the complexity of this patient. Bile is also not available. Then you don't have the pancreatic juice also. And there's a probability that the insulin also may not be available. It's a probability. But because the tumor is located at the head of the pancreas, the availability of insulin will be higher because insulin is more or less is being secreted by the pancreatic body or the tail. And even if it is head is being impacted, the insulin will be available. Just for your understanding, I made it over clear which part of the pancreas will secrete what all kind of juices more. So you should be knowing about it. A periampullary insulin will be available. But if the tumor is quite inside the body of the pancreas, insulin will not be available. Then again, that patient will be either a diabetic already at the time of reporting, may or may not be diagnosed. They will say, Ki, I was not diabetic, but now I came to know during the investigations. These are the things are the result of what I did mention. There can be a gut barrier dysfunction due to inflammation leading to increased permeability. I'll describe this in the next few slides. Microbiome changes may exacerbate the malnutrition. So how to counteract? What are the nutritional interventions? So to keep it very simple, we have to counteract the inflammation. And you have to provide, to counter this one, you have to give an anti-inflammatory diet. In very again simple languages, what is anti-inflammatory diet? It is more of omega-3 fatty acids, good amount of good quality proteins, first class proteins, good amount of fibers throughout the day, at least 18 to 20 grams or maybe more than the 30 grams. If you can provide, it will be much better. But having seen that the patient's consumptions are normally less, even if you can reach 20 grams of fibers, it will be really appreciated. Fructo-oligosaccharides, you want to increase the microbiome, we have to nurture the microbiome, we have to give good amount of fructo-oligosaccharides, and yes, of course, good calories as well. These calories has to come from good fats, so that we need to take care of. To increase the calories, please don't increase the simple sugars. Nutritional supplementation is needed for these patients, so you have to give some good amount of protein, energy, dense and omega-3 dense supplementations. And importance of early nutrition screening is very important. The early you catch, the better intervention you can do. And or the patient comes to you quite late, your intervention will not have any kind of an impact on the further weight loss, and maybe the impact on the patients for the nutritional status, which has an impact on the treatment outcome. All those things what I spoke about, a lot of research is underway to target these metabolic activities of the cancer cells. Now we have come out with the immunotherapies, which actually is training these T cells and making them more stronger and being reinserted into the body, where they go to the cancer cells and start attacking and killing them. That is actually the role of the T cells when the patient, when we all are healthy, that is what it is actually doing. But when the cancer is grown, it has lost its profile of attacking the cancer cells. So what the immunotherapy is being doing, it is being removed, it's being trained. It is something like policeman is being trained into army personnel and sent into the front where it is fighting those enemies. Similar kind of a immunotherapy, I can describe it over here. So these emerging therapies now actually seeing into attacking the metabolic functions of the cancer cells, or even the production of these pro-inflammatory markers, that is the interleukin 6 or interleukin 1 tumor necrosis factors, whether these can be attacked to stop the cancer growth as well. There are also research which is going on to see that the pathways which lead to the cancer growth, one of them is the mTOR pathway, AMPK pathway. These are some of the pathways, and PPAR pathways, which help the cancer cells to grow. Whether these pathways can be stopped. And there is a potential for combining metabolic and nutritional therapies to improve the outcomes. So these are all this research which is very heavily going on as of now. In the coming few years, we will be really having good understanding about the inflammation and the nutrient care what has to be implemented. To end up the talk, the last thing what I would like to talk about the microbiota. Microbiota has a very good impact upon reducing the inflammation. But if the microbiota is being disturbed, if there's a dysbiosis, then yes, they are going to function as a helping the tumor for the promotions. So this is why we would like to have a good microbiota. This is where they too will be taking care of all the immune functions of the of the body. And we have seen that the cancer cells attack the immune cells and change their profile, the way they have to work. So if you have a good microbiota, that can take care of and that can initiate the stoppage of the cancer cells to grow. If it is not taken care, as I said, the cancer cells are growing as the microbiota is being not into good standard kind of a thing, what is actually the body needs to be. So microbiota is one of the things why it is being required. And we all know microbiota is also giving a birth to many of the comorbidities. And if you have, the patient doesn't have a good microbiome, even the response to the therapy will also be poor, and the anti-cancer immune response will also be affected. So seeing that, that is one of the reason why I say, what kind of diet you have to give. The fructooligosaccharides are the ones, fibers are the ones which are going to nurture a good microbiota into our system, which can reverse all these abnormalities. So to conclude, inflammation, metabolism, and nutrition in cancer are interrelated. Chronic inflammation is central to metabolic dysregulation in cancer. It contributes to poor nutrition status and cachexia. Early intervention with the nutritional and metabolic therapies is critical for improving quality of life and treatment outcomes. Thank you so much, and I look forward to an engagement with the audience.
I think that was wonderful. You're such a beautiful teacher. That is the storytelling. It's not easy to work on metabolic pathways, and the way you've explained the cellular pathways, fantastic. I now make the floor open for questions for the audience. Ma'am, if you have to comment, over to you. There is a question in the message box. Can I take it, ma'am?
Please go ahead, Geeta. And thank you, Shiva, for that excellent talk, or I would say a class. You really
Thank
taught us well about cancer and inflammation. I think it is much needed for the audience. And look at the audience. You are such a popular and wanted speaker. Thank you so much. See, our audience is really in huge numbers, and that tells everything. So thank you once again. We'll take the question and we'll discuss few things as the
Sure.
question answer goes. Thank you.
We have 10 minutes, so I think we'll take few questions which are important. Please keep posting, and then if we couldn't answer them, we'll get back to him, and then we'll ask him to answer it through virtual way.
Yeah.
Gaurav Banerjee says, is there any evidence supporting the uses of specific dietary patterns like alkaline diet, macrobiotic diet, any specific diets which supports cancer therapies, any pattern?
To substantiate what I spoke about in the last almost 30-40 minutes, there are some evidences, and there are some kind of observatory studies where they speak about the Mediterranean diet, where what all nutrients I spoke about, reducing all the inflammatory nutrients, inflammatory food items, simple sugars, and increasing all those fibers and having good amount of quality proteins and everything. The Mediterranean diet is the most balanced one, rather than going for a drastic modification of the diet. And this is what actually I propagate every time, because Mediterranean diet is a very anti-inflammatory diet. So it does take care of, if it is being practiced the way it is being actually proposed. And also that one, just not following the diet, the patient has to be physically active in whatever the capacity. The patient can do some kind of an exercise, because just having a good amount of nutrition will not show you the results. It has to be complemented by some kind of a physical activity, which can be a yoga, which can be any kind of stretching exercise, or maybe if they can have some kind of a little bit of weight loss, but any kind of resistance exercise has to be done under the observation of the oncophysiotherapist. So I always tell people, don't tell what kind of exercise they have to do. Tell them they have to be physically active. And whichever the anti-inflammatory diet, whichever they are following, anyone can go for a microbiota diet. There's so many things, can you just name, in one of my book, I think around 43 or 48 different type of cancer diets are being mentioned. The more, the stricter way you prescribe a diet, the lesser the compliance. Keto diet is very much on us principles of what I spoke about. It is very much on us principles of what Warburg spoke about. But why the keto diet has not shown much of the result? The only thing is the compliance is poor. Keto diet is not wrong, but keto diet's compliance is so difficult for all the cancer patients. They have anorexia, they have delayed gastric emptying, they are vomiting, they can't smell properly. There's so many things they are undergoing. And when we prescribe a keto diet with all those restrictions, we are carb eating, and the main thing we are reducing. If you have a very dedicated patient who can really follow, I support for that one. But having said that one, I say that the Mediterranean diet is one of the most balanced anti-inflammatory diet, what we follow, and we are quite good at that. This is what is my take on this.
How about fasting? Because there's a question again on this, supporting with the what discussion we're having, the IF pattern, prevention or a therapeutic cure? How do you look at it for a cancer therapy?
Again, the same answer can be repeated over here. The fasting is principally it is correct. In what way principally it is correct? If the patient is fasting, there are two things which are happening. There are reduction of cytokines. That is one thing is happening. And we all now know that the fasting increases the immunity functions. There are two good things which are happening. But if the patient is having a good weight and the consumption prior to the fasting is really good, this is a really good option. One can explore this option. But if the patient is already lost, as I said, more than 7%, 10% weight loss, having anorexia, telling someone to again fast those 24 hours before the chemo, it is really harsh on the patient. This, we really don't know what may be the outcome as well. The patient is already compromised with the food intake. Further, we are asking them the patient to go on a very stricter fasting. So this, I don't propagate this one.
End
But
of
if
the
you
day,
have, as I
calorie
said,
restriction.
no weight loss, patient is dedicated, can be taken care of the nutrition after 24 hours, you can try it.
Yes, you're emphasizing on holistic nutrition, not calorie restriction with fasting, which makes a lot of sense. There's a question from Sohoni. I think she's raised her hand also. Sohoni, would you like to ask your question yourself instead of me telling? Go ahead. Sohoni? Okay, I'll ask a question. It's about micronutrients here now, vitamins, minerals, all that. She wants to know that what are the supplementation which is expected, because she's come across oncologists restricting supplements for cancer patients. So little note from you and your experience about it.
Any oncologist interfering with you, the dietitians I'm talking about, first you have to have a good knowledge about, today you understood what cancer is about. Again, I have not elaborated many other things which will come into the effect in compromising the food intake. You can tell the patient, the doctors, a patient whose appetite is low and maybe the consumption is low because of the tumor, the obstructions, the inflammation, the symptoms, and there are many other things which is restricting their food intake. Not only that one, most of these cancer patients travel from one place to the other place. They are not from their home only, they are not taking the treatment. See, someone traveling from their rural areas coming to the cities and taking treatment. Do you expect them to consume 2000 to 2200 calories daily on a regular basis? Is it possible? Which of these patients, even I would say, any 3 days continuously will consume 1800 calories? Very rare. Specifically on the when the active treatment is going on. So once you put it across to them saying that a patient who is exhibiting all these symptoms with such a kind of an inflammation, and if the patient, see, supplementation is not your first option. The first option is your counseling. And you can always say after even counseling, if the patient is not able to take the required amount of calories and proteins and all those nutrients what we speak about, supplementation has to be done. And even the guidelines are very much clear. You can refer to the IAPEN guidelines. You can refer it to the ESPN guidelines. You can refer it to the Australian or the Spanish guidelines. Everyone is saying on the similar lines. The first option is you counsel them and see that whether the counseling is enough for them to improve upon their nutrition. 70-80% of the time, it is not possible. You have to supplement it. But supplementation, as I said, should not be a priority. Then ethically you're wrong over there. You have to talk to the doctor, the oncologist, and make them understand. And I think if they are made to understand why you are supplementing it, they should consider and they should leave you free hand to practice over there. And most of the times, every dietitian had some problem or the other for recommending ONS, or they directing that you have to be prescribing this ONS itself and no other brands, and such kind of guidelines are being passed on to the practitioners. You have to resist for this one, and you have to make them understand why it is not being taken into the right perspective of practice. The second aspect is, if at all they are recommending some kind of ONS, you have to show that what are the deficiencies in that one, whether the omega-3 fatty acid is there, required amount of omega-3 fatty acids if I have to give, or not only the omega-3 fatty acids, the fiber, or the even, as I said, the patients are anemic as well. Does it has adequate amount of iron and all other nutrients, B12, folate, folic acid? So they will never ever have any kind of an answers to this one. For that, you be prepared with the question and the answers, put it across, read the guidelines properly. If they don't listen, send them the guidelines to them, WhatsApp them or mail them, let them read about it. Initially, they will be troubling you, but knowing that, yes, you are well educated, they will never ever come and ask you for this one. We have undergone all these things and successfully we have come out.
Fantastic. I think basic knowledge of cellular health, molecular pathways, the root cause and the functionality, and we call it as functional nutrition, is a very integral part of our education behind the scene to get more and more confident dietitians taking us ahead. I think that's the whole goal of this VNA live session also, where we try to put this emphasis that learn the basics, and then people like you, and when you teach them and when you come to us and make us understand this, it makes it more effective. We'll take a last question, then we'll have a note from Dr. Salomi ma'am too. Ifra says, what should be the way to overcome anorexia in patients with chemocycles and focal wall, that is endocarditis, with renal dearrangements?
Can you please repeat the question?
Yeah, what should be the way to overcome anorexia in patients with two chemocycles who have undergone two?
Overcome is.
Yeah. How to overcome anorexia in patients with
got it. Yeah.
two chemocycle and endocarditis and with renal derangements.
I think he
So
can
renal,
also question.
endocarditis and chemo and poor appetite.
Yeah. Here you are talking about two different and opposite kind of an intervention. If it's a CKD patient, renal insufficiency is a different thing. CKD as a diagnosis which has been diagnosed, your always priority is to preserve the kidney. You cannot say because the cancer is there, I would like to give 1.2, 1.5 grams of protein because the guidelines are speaking about. I would like to make it very clear over here. The cancer guidelines are applicable in a normal circumstances where there are no other comorbidities. The one you mentioned about the renal complications. If there's a renal complications, hepatic complications, your priority over here is to preserve that organ. If you just look for the cancer is a very chronic thing, which is not going to end maybe tomorrow, day after tomorrow, or the patient will be cured of. It will be there for the coming months and years as well. So if you lose the organ, the patient may not survive. Organ specific guidelines are being followed. Medical guidelines will be followed. Can you mute? Yeah. And now coming to the anorexia part. However, the renal complications may be there. You will not be stopped by giving omega-3 fatty acids. Omega-3 fatty acids doesn't have any bad effects on the renal complications. So you are free to use omega-3 fatty acids over here. Reasonable amount of whatever the recommendations for the renal complications, the proteins are mentioned, provide that much. And of course, nowadays, even for the renal complications, the microbiome or the fibers are being spoken about very much in favor of it. So except for the protein content, you have all the nutrients which can be given to the condition what you refer to me.
Absolutely. I think we'll stop with the question answers now. You can always mail us your questions if you have any, because it's already 5. And final note from Salomi ma'am, and we will take a call after this. Yes, ma'am, over to you.
Yes, thank you once again, Shiva, for answering all the questions. I think we really have to look into a very in-depth approach for each symptom and for the mechanisms involved in different cancer. Like your case was pancreatic periampular cancer. When you have pancreatic insufficiency, you will also have renal insufficiency. So what are the reasons and causes for renal or a creatinine high? It may not be just CKD. It could be just because of dehydration or even because of the treatment of chemo. Sometimes we have a higher creatinine. And that's why we don't need to address it at that particular time. If you give 1 gram or 1.2 gram. But here, as a nutritionist, I would tell all the participants that you must screen and assess properly. If you are assessing a person nutrient intake, calories, protein, and the other micro, you will know where the patient is deficient, what he or she is not able to make it up in a diet, and that you give it. Because here we are having an overall balanced diet approach with some anti-inflammatory, your micronutrients like omega-3, zinc, and selenium, which we are using for cancer patients. So I think if you're, as Geeta rightly said, the basic knowledge is good, then I don't think we really need to go out of the box and prescribe so many A, B, C, D, and everything. If you give right assessment, if you do, you know what the patient can take, what cannot take. If you definitely not reaching with food advice approach, you have to give supplements. And I don't think any oncologist can challenge you when you are meeting the requirement. It's just that you need to meet the requirement of whatever cancer it is, whatever grade of inflammation it is, and you must meet. Another point I must make it here, I hope Shiva will agree with me, is when there is CRP very high. There are studies showing that when we give high protein with CRP high, it is going to increase the CRP. So to go start with 0.81 gram with 1.8 create and CRP high, it is better. And then once the CRP comes down, you can give good protein. So ratio of calorie to protein is important. Another thing is we need here to our cachexic patient, to our anorexic patient, to give more calories rather than giving more of protein. And already when you are giving the calories, you are going to meet the protein requirement simultaneously. So we don't have to go very out of the box and say, no, I'm only concentrating on high protein and not calorie giving foods, because we saw we can give good fats, give good calorie, and then simultaneously meet the protein requirement. If not, give a supplement. You can also use some modular protein when it is needed to meet that much requirement. Otherwise, with your fiber and your calorie and your dense protein and energy requirement, I think you will meet it. Omega-3, one more point I would tell to this audience is cachexia. If you see a patient early, okay, before the cachexia onset, and introduce omega-3, see there are a lot of researches, Shiva will agree with me, early, then we can prevent cachexia. As a nutritionist, I'm not only managing, I'm also looking at prevention. So if preventing cachexia is possible when you see the patient early, early onset, and then if you start omega-3 early, you can prevent cachexia and giving good energy and protein at that time. So that is, there are some evidences for these also which you can use. And of course we have guidelines for omega-3 branch in amino acids and glucose. I think Shiva, you must take one talk on myths and fads, because so much of milk and so much of iron supplementation, potassium supplementation, and of course if you are not very vigilant in seeing the reports biochemical, you will have these questions. If you see the reports, you've got to correct these abnormal values of these nutrient or an electrolytes or other parameters, and you will do accordingly. But there are so many myths and fads exist which are also there among the oncologists, which if we can clear, I think our budding dietitians and our practicing dietitians with onco patients will be really guided. So one more opportunity for Shiva to be on our platform if and whenever you have time. I would leave, because whenever we are doing inflammation and this, we are doing some series on a particular topic, and that's why we were actually insisting on you to give a talk during this period. Thank you once again. He always tells me, ma'am, you don't have to thank, but you are very nice to say that. But I'm not very nice to not say that, because I really want to be grateful to give your time and your knowledge to our audience. Thank you once again. Geeta, you can thank the
Yeah.
audience and the
Thank you.
team and conclude.
Thank you. I think, Shiva sir, in spite of busy schedule, you made it. And we were very smart enough to route it through Salome ma'am, because we know you wouldn't say no to her. So it was something which we really wanted you to be here. And I think you really sounded it so well. You made us to think, yes, it's not just MNT which we need to think. We need to go behind the scene and learn a lot of pathways, processes, root causes, cellular interactions, and the root cause. Without that, nutrition is not possible. Glutamine or branch-chain amino acid or essential amino acid is something which we really need to think, not just proteins. And that the time has come and the AI will take over us. And you made us think that these are the things which AI won't tell you. Now here you have your expertise, and it's time we start putting our foot down and talk about all this rather than talking about protein, calories in a very specific way. So thank you very much. It really made all of our day with a lot of thought process, food for thought from you. And this wouldn't have been possible without our mentor, Salome, ma'am. Thank you always for being there, ma'am. And behind the team, I think, behind the team, Vishakha, Mr. Date, Nitin, and all that definitely make it possible. And my two other colleagues, Nazneen and Richa, are not there today. And definitely they are a part of this BNA life always. And to all the audience who come every month in such large numbers. And today it was excellent. And I think the speaker says it all. And I think keep showing this love and blessings to all of us. And thank you very much once again. And thank you, each one of you, and have a good day. We'll connect. Happy Diwali also, same time. And we'll connect next month with another wonderful speaker and a good topic. Thank you very much.
Thank you. Thank you all.
Thank you. Thank you.
Thank you, Geeta.
Thank you.